Hello, hello, hello. Can you hear me okay?
Yeah, I can hear you great, thank you. Yeah,
fantastic.
Yeah.
And you're 12 hours in.
We've officially hit the halfway mark, Rob. Yeah, 12 hours. I don't know if you've had a chance to listen to any of it so far, like throughout the day. I imagine you've been busy working, but we've had some absolutely stellar conversations. Yeah, it's been a real privilege. Yeah, so Rob Paul, sorry, has literally just popped out. I think it's the halfway point kicks in about every hour. I can definitely feel it in my body. I keep feeling, oh, I just need to just need to move. Yeah, so Rob, you have I mean, you've been involved in Mercy for such a long time, and you've got so many different hats that you wear. You are a consultant psychiatrist, director at Mind and Soul. You've recently helped write a paper, which I'd love to talk about, on the importance of, I don't know if this is the right summary, but holistic approach to mental health services on a government level. And so there are so many ways in which I know you're going to be able to contribute to this conversation. But I would love to start off with you in terms of what led you to this world of psychiatry, what led you to this world of mental health. Where did it all start? Where did your journey start?
Yeah, goodness me. So it started in a really surprising way. I don't particularly have any early experiences of mental health difficulties, either family members or myself. I suppose I've got what you might call sort of robust mental health, which usually means that I don't think about things very much sometimes, which can be a problem. But honestly, there was nothing particular in my sort of background or family members. I do remember when I was at university being aware that one of the other students sort of dropped out, and it sort of became clear later that they had to leave for mental health reasons, but I wasn't really aware of that at the time. And then I think I just was almost sort of catapulted into it when I did my psychiatry placement when I was a medical student. And when you're in your sort of fourth or fifth year of medical school, you basically spend a few weeks in each specialty. So you spend a few weeks delivering babies, a few weeks in surgery, that kind of thing. And I found it absolutely fascinating. And I discovered that I really like working with people who are quite severely mentally unwell, often psychotic. And you might think that's a slightly weird thing to enjoy doing. But, my wife's trained as a primary school teacher. And to me, being in a classroom full of 30 kids, well, that's my idea of hell. I can cope with small numbers, and I've got two of my own, but, large numbers of children and having to make them learn things, that terrifies me. Whereas it energizes her. And for me, talking to people who are psychotic or very unwell is something that I really enjoy. And I think the other thing that I discovered about that time was that I used to get really frustrated when mental health was negatively portrayed. And I remember one of my classmates did a project. One of my classmates did a project on episodes of Casualty, and he watched 50 episodes of Casualty, which is a great thing to do when you're a student. And he sort of looked at the portrayals of mental health conditions in Casualty. And you've seen enough of these sort of medical dramas, and it's always about some little kiddie or someone gets cancer or something like this, and it's all warm and fluffy. And what he realized was that 90% of the sort of portrayals of mental health or mental illness were quite negative, or the person seemed to be stupid or dumb or something like this. And that sort of, I think, really kind of got my goat. And I think what I realized was that there's things you like. I mean, for example, I like going for a walk in the countryside, but it's not what I want to spend my life doing. What you want to spend your life doing is when what you like coincides, and hopefully what you're good at, coincides with what the world needs, but more importantly, coincides with what you can't not do.
Yeah.
And I think I became aware about that kind of time that I couldn't not do this. I was going to go into this specialty of medicine, even though perhaps it's one of the less glamorous ones, because I thought it's so important. It's really important that we get this right. It's really important we make a bit of a noise about it. And so I think that really got me sort of interested in it. And also I thought it's a speciality that's going to change completely during my lifetime. You know, when I trained, we had medications that effectively treated the symptoms of illness. You know, they raised serotonin in depression, or they lowered dopamine in psychosis. But those are the end product. It's a bit like taking paracetamol for a headache. You know, sure, you're removing the thing that is causing the pain, but what's the cause of the pain? You know, you're removing the pain symptoms, but what's the cause of the pain? And you know, we're now beginning to understand some of the neurobiology involved in that, where we've got medications now coming online for dementia that can actually alter the disease process rather than just stimulate the remaining neurons. So, you know, it's a field that I expect by the time I retire, or by the time I die, we will understand so much more about the human brain. So I thought this is you know, one of the last great things. I mean, the heart, we know how the heart works. You know, it's got 4 chambers, it pumps blood around, it goes wrong in a number of ways. The biggest thing by far in heart disease is whether or not people smoke and are fit and take exercise. You know, whereas actually, you know, we know so much more about the heart, and that's the big sort of improvement area. But the brain is such an unknown thing, isn't it? So I realized that, and then I did my sort of first year, my sort of apprenticeship year in medicine, working as a doctor, just on a general medical and surgical wards, and people were coming in with fairly typical things, you know, and to a certain extent, I felt that once you've seen one case of pneumonia, you've seen them all. And sure, there's different severities, but by and large, you give them oxygen, you give them antibiotics, you might need to give them some diuretics or some steroids, but it's a fairly simple process to treat pneumonia by and large. Whereas what interested me far more was the wider sort of psychosocial thing around this person. Sure, they came into hospital, but were they going to go home again? How did they cope with getting ill? How did they cope with perhaps some disability they had afterwards? How were the family going to cope? It was that side of the medicine that I think, to me, made it more interesting, rather than that sort of one-line diagnosis of pneumonia. It was the wider thing. So I kind of got into it from there, and I thought, right, I want to study psychiatry as a medical specialty.
And how talk to us a bit about what the field, I mean, you've alluded to already, the kind of the massive change that we've seen over the time. Talk to me a bit about the difference in the field when you first entered it, and what we see today.
Well, I started in 2000. The first year I worked in psychiatry, and I was training in Leeds in Yorkshire, and I went for my interview. You know, we might talk about that later, because that's quite an interesting story. But at the end of the interview, they said, "Have you got any questions for us?" And I said, "I would love to work in Hyroids Asylum before it closes." And Hyroids was the old asylum near Leeds, just north of Leeds. I think it's now been turned into posh flats, you know, like a lot of these places have. But it was still a working hospital then. And a lot of the wards had been closed. You know, most of these asylums used to have 2,500 patients. I think Hyroids had 2 train stations, you know, farms, that kind of thing. It was a huge enterprise. It had a chapel. It had a pub. You know, I mean, you could live on site and never leave. You could be born there. You could die there. And back in the day, it was a huge enterprise, and rightly so. The asylums have largely emptied, and there's a number of reasons for that. One is that people were put into asylums for incorrect reasons, for social reasons. You know, famously having a child out of wedlock or something like that. You know, people were put away for a variety of things, but people were also put away for mental illness, which back in those days was incurable. And most mental illnesses, like schizophrenia or very severe depression or bipolar, they're what we call relapsing remitting conditions. They will eventually get better. that the natural course of a psychotic episode or a depressive episode is between 6 and 12 months. So you will eventually get better from that to some degree. You may have another episode, but during that time in the asylum, you're stripped of identity, friends. You know, people in psychiatric hospitals get far less visitors than and cards and flowers than all other specialties. We know that both from, you know, just intuitively, but also from research studies as well. So people would go into these things, and it would be perhaps they would never leave, or they would leave several years later to a very different life. And there wasn't really effective treatments. If you've watched the film A Beautiful Mind, you know, one of the earlier treatments was the beginnings of electric shock therapy and that sort of thing, but it wasn't particularly effective. And then what you had in the 1950s was huge changes with the development of antipsychotics, and then fairly soon after with antidepressants. And I think antidepressants in particular can get a bit of a bad press nowadays. You know, we think, well, you know, how effective are they? We seem to be swimming in them. Everyone seems to be taking in them, and people are still unhappy. And I think what I'd say as a doctor is perhaps what we're dealing in those situations is not necessarily low serotonin. But when you think back to that asylum era, and people would take to their beds for 6 months or longer. And these were people who were raving with psychosis and were brought into sanity with antipsychotics. These are people who were morbidly depressed and lying in their beds, wasting away, who got up and walked. So that transformatory sort of era in the 50s and 60s with medication was absolutely huge. And medication undoubtedly still has a place today. But the bottom line is that we don't actually see illness that severe anymore. And it's the more severe illnesses that are more biological and more responsive to medication. I think some of the depression that we see nowadays is perhaps more rooted in upbringing, childhood, that sort of thing. It doesn't mean medicine's got a place, but people are not so profoundly disabled. So that was a massive era. And when I first started work, I think Hyroids had, 200 or 300 beds. And those beds couldn't be cut back anymore, because that number of beds is needed. A city the size of Leeds will need 100, 150 acute psychiatry beds for people to be admitted to. Edinburgh, where I work at the moment, similar size city, ever so slightly smaller, it's about 100 acute beds. And then there was obviously beds for old age, intellectual disability, forensics, that sort of thing, CAMS. So, you know, a small 100 number of beds. And those beds were re-provided into 3 modern facilities around Leeds. And I said, I want to work at Hyroids because I want to experience that asylum before it goes, just to remember, be aware of how bad it was. We used to have this phrase, you know, when you drive up to Hyroids Asylum, you leave the road going out of Leeds, and many people will have driven past it, and you drive out. I think it's the A65. You drive out, and the road to Hyroid, it turns off to the left, and then it goes sort of around this curve, and then eventually there's this big reveal, and Highlights appears before you. And a lot of the asylums were designed like that, and it makes us understand phrases like, "Oh, he's gone round the bend." What does going round the bend mean? Does it mean going round the U-bend of the toilet? No, it means he's gone round the bend in the road. And the other phrase that sort of dates from that time is, "Oh, he's gone out of sight, out of mind." And literally, he's out of sight, he's out of his mind, and he's also out of our minds, because we've taken these people and we've hidden them away and said, "Look, we don't want you in our society. We want you to go over here." So the closing of the asylum era and care in the community, it's had its faults, no doubt. You know, some people I think were attempted to go into the community, perhaps who weren't ready or weren't equipped or had become too institutionalized. But it was so important to get away from that mentality of out of sight, out of mind. And what we've seen over the last sort of, sorry to interrupt,
Rob. I'd just be really interested to know what, because the history of this stuff is fascinating, and it's obviously so closely interlinked and interplays with society's views on mental health, in terms of like how we treat it. is completely intrinsically linked with how we view it. At the time in that period, so 1950s-ish, what was it that led to the realization that this was not the right way to treat people, and we needed to remove the asylums and integrate people back into society? What instigated that change in the first place?
Yeah, I think there are a number of different things. I think one of which perhaps was just, like I say, we had medications that could actually treat people.
Yeah.
Didn't cure them, but we could remit the symptoms. So that was a big change. The people didn't actually need to continue being so psychotic or so profoundly depressed. I think the other big change was just a growing sort of social awareness about, you know, the problems with institutions, and that, you know, that wasn't the way to run things, and that's led to a number of institutions being undermined. You know, my personal view is that we've gone rather too far down that route, and we're now sort of undermining and challenging every institution, including important institutions like marriage and other things like that. But there was definitely a sort of social vibe going on at that time to challenge the institution, and sometimes that was very literally to challenge the institution. So that was going on, and I think the other thing was just a greater focus on care in the community. So I remember talking to some of the psychiatrists who were working at that time, and you know, the fact that you can actually eat with medication, but even without that, you can actually train people skills. You can give them skills. You can teach people how to budget, how to live independently, how to structure their week again. You can deinstitutionalize people, if that makes sense. Or, you know, one of the problems with schizophrenia is that it has the psychotic symptoms, sure, but it also has what are called the negative symptoms. So people lose skills they used to once have, but those skills can be retaught and can be retrained. So the whole branch of sort of rehabilitation psychiatry grew up, and psychiatry in the 70s and the 80s began to develop community mental health teams, home treatment teams. In Edinburgh, we've got something like 60 psychiatrists, of whom my guess is that about 40% of their time is spent working with outpatients. Sorry, about 40 of them work, 40 whole-time equivalents. So 2/3 of their time is spent working with outpatients. Now, if you contrast that perhaps to a surgeon, again, we have a similar number of surgeons. All of their surgery takes place on inpatients. There's a move towards day surgery.
Yeah.
But fundamentally, surgery is an inpatient procedure, and likewise, something like you know, cardiology or something like that. You know, people are coming into hospital with heart attacks. They are having high dependency. They're having cardiac procedures in hospital. Sure, there's the outpatient clinics, but it's still all hospital based. And when it gets to you know, the person's well enough, they go back to their GP. Whereas psychiatry for many years has been developing this sort of community care model. And we're seeing that now in the acute hospitals. You know, if you go into, if you have a medical issue and need to be admitted to hospital, you might go physically into hospital, or you might be treated on what they're starting to call hospital at home, where you perhaps get a visit twice a day from a team of nurses and physios and doctors who come out from the hospital and effectively run the equivalent of a ward, but in people's homes. And that's, first of all, a whole lot cheaper. Secondly, there's a whole load less of hospital-acquired infections. Thirdly, people have got their own possessions around them. They've got their loved ones around them, et cetera, et cetera, et cetera. And this whole hospital at home thing is being treated like a wonderful new thing that someone's just invented. And we're sitting there going, we've been doing this for 30, 40 years. You know, nothing particularly new about this. We've had intensive home treatment teams for 10, 15 years that can treat people who are, because if you think about it, if you go into hospital, most of the time you just sit there. Once, twice a day, you get a visit from a doctor. A few times a day, you get your pulse and blood pressure taken, and you might get a one-to-one session with a physio or a nurse or something like that. We can do that in people's homes.
Mm-hmm.
So I think that's something that mental health services have been further ahead with. And I'm aware that I've been talking quite a lot about psychiatry, but it's important to remember that modern mental health services are, yes, psychiatrists, but also psychologists, psychiatric nurses, mental health social workers, mental health OTs, peer support workers who perhaps have had their own experience of illness. what you might call standard support workers who are just working as sort of assistants within the team, but they often have a lot of skills and experience within them. So it's very much a multidisciplinary team. And again, if we take the example of a surgeon, you've got, one surgeon, and then there might be a junior surgeon and perhaps a nurse specialist. And then there's nurses on the ward, sure, but not in the community. Whereas in the community, the psychiatrist is the least numerous person. The building where I work, there's 4 psychiatrists work there, and there's about 100 staff in total doing various different types of community mental health work. So the medical bit is a very small part of it.
Yeah, and could you just, for those of us or for anyone that's listening that doesn't quite understand, doesn't necessarily understand the differences between those terms and what separates out a psychiatrist from a psychologist, from a mental health professional, specifically in the life of a patient, what is your role and when does that overlap with somebody else's? How does the system work?
Yeah, a proportion is generic. You should be able to start a conversation with anyone, so everyone will have a basic understanding of the different types of mental illness and that sort of thing. But this is very, very broad brush. Support workers will support people to work towards their goals. Nurses will primarily perhaps deliver a plan of care, and they'll sort of set that up and structure that and put that together. Occupational therapists perhaps help people set goals and work towards them in a very particular way, which could be to increase their function, to get them out and about, to improve their cooking or their organizational ability or their ability to deal with agoraphobia, that kind of thing. Psychologists and psychiatrists are the ones people often get confused. Apart from the fact they both begin with psy, that's about where the difference ends, the similarity ends. Psychiatrists are doctors. So I'm a doctor. I have a medical degree. I prescribe medication. I have inpatients. I have outpatients. I have medico-legal rights under the Medical Act, which allow me to give these treatments to people. Under the Mental Health Act, I have the powers and abilities to detain people in hospital. So it's a very medical kind of role. Obviously, I can do the other stuff. I do have a qualification in therapy as well, but it's not my main thing. Psychologists will have a psychology degree, and they will be trained in usually 1 or 2 or 3 types of therapy. So, for example, cognitive behavioral therapy, CBT, or psychoanalytical therapy, and they will, generally speaking, deliver weekly hour-long sessions of therapy, really getting into the sort of detail of people's thoughts. It's in some ways similar to a counselor, but a counselor tends to work with the everyday problems of life and use the person's own resources and just some space to work towards that, whereas a psychologist will work more in the illness domain, and the models and levers they have are more related to symptoms and illness. That's a wild simplification, if that makes sense. But yeah, psychiatrists and psychologists, people will see me probably once every few months. They should see a psychologist every week or 2 if they're seeing one.
Yeah, no, that's a really helpful overview. When is it obvious when somebody needs to go to a psychiatrist versus a psychologist or a therapist? Like, at what point does the threshold cross? And the reason why I ask that, I know that you will, obviously mental health is a broad spectrum, and when you're talking about psychosis and schizophrenia, like those are the things that you can kind of see it's on one end of the spectrum. But what I'm also conscious of is that when we talk about stigma and stereotyping, it often happens at those transitionary periods where it crosses over from one thing into the next, and I think people's own reluctance to necessarily pursue the help they need is because they don't really know how to cross those boundaries and those thresholds. Speaking to that a bit.
Yeah, it is quite difficult. I mean, I think there's some stuff that's very obvious. Basically, if it looks very medical, so if it looks as though you could almost sort of tell from the far side of the room or the far side of the street that the person is ill, you probably need to be seeing first of all your GP, perhaps to be excluding other types of illness. It could be a urinary tract infection. that's making someone behave in a strange way. Or they could be hypoxic because their lungs are not working properly and confused and delirious. But assuming it's a mental illness, it's likely perhaps either to be, the beginnings of dementia or a psychotic illness, where it's quite obvious the person is ill and different, and there's something really not right here. I think in those situations you do want to be seeing a psychiatrist. What's slightly more difficult is when it is extreme versions of normality. So someone is very anxious, or we can all be a bit obsessive compulsive, but someone is really doing lots of checking and compulsive behaviors, or they're very depressed, or very agoraphobic or something like that. There's sort of extreme versions of things that we can understand to some degree. It's just gone way more. And there's a range of different approaches to those things. And I think to a certain extent, it's probably unfair to expect people to work out exactly who the right person to see is. I mean, one of the things that we offer in the area where I work is we say to the GPs, look, just put your referral in. Describe it as best you can, and we'll work out which bit of the service needs to see this person. But likewise, please don't promise anything, because if you promise that the person's going to see a psychiatrist and we think actually a psychologist is best, they're going to be disappointed.
Yeah.
And likewise, quite a lot of places are starting to offer sort of walk-in one-stop shops where you can sort of basically go in and talk to someone, and that person could be a nurse, or it could be someone with some peer experience themselves of mental illness, and they'll take your initial story, and then they've got other people within the team. There's a sort of phrase, right treatment, right place, right time. You should be able to go in and sort of speak to someone and actually have a first conversation, and then that person can sort of direct you onwards, because there's also in many areas such a huge range of resources. So it could be you end up seeing a psychiatrist, but it could be there's a local men's shed that offers, sort of DIY and sort of carpentry and practical skills that actually is a really important social environment for men who might be struggling. Or it could be a walking group, or it could be a physiotherapist, because initially you go for a bad back, but actually the physio works out actually it's really more about your mood, and they could be the person who kind of really gets you thinking about it. So in an ideal world, I think we ought to be able to just talk to anyone, probably a health professional at some level, and then they should be able to sort of direct you onwards, because this is what I do every day, so I can work that out. But for most people, this could be the first time in their life, or it could be the only experience they've got, or they haven't got anyone in the family who struggles in a similar kind of way, so they don't know. And short of Googling stuff, which is always slightly dangerous, they perhaps do just want to just go and sort of just talk to someone. Your local GP is a good place to start, or your local mental health NHS may well have some sort of one-stop shop that you can self-refer to. So I think either of those are a good place to start.
Yeah. That's really helpful. Thanks, Rob. One of the things I'd really love to touch on and chat through is, and hearing you talk about the history of psychiatry feels like it's a really helpful insight as to why you've championed what you have championed. So it's about the paper that you were part of producing and putting together. I can't remember the exact name of it, my apologies. But it seems to really be about what you've just described in terms of the psychiatry history of, rather than removing people from society, you put them into society, because actually all the different components are completely intrinsic to the well-being of that individual. And I think I'm right in understanding that was kind of the premise of the paper, was that we can't just look at mental health in isolation, because it's intrinsically connected to how we're dealing with poverty, how we're dealing with homelessness. It's about the entire circumstance and the surrounding the individual. I don't think we've done that justice. So could you tell us a bit about the paper?
I'm trying to remember which paper it was.
It was the one you sent round to the board group. No, I know which one that is. Yeah, it wasn't my paper. But it was it one you were just circulating?
It was just one I was sharing. Yeah. So I sent it around the Mercy board, because I think you're right. There's always a degree of components here. So like I say, I'm a doctor. I know our understanding about the human brain is growing and growing and growing, and I expect that we will be able to do brain scans for psychosis or depression or something like that by the time I retire. We can already do them in research studies, and I think we'll be doing them in clinical practice fairly soon. But that's just the biology. And if you're a biology person, there's the saying, isn't there? If all you've got is a hammer, everything looks like a nail. But sometimes actually it's a screw, and you need a screwdriver. Yeah. So biologically, there's obviously some treatments, and like I say, and antidepressants are absolutely transformative for a good percentage of people with depression. It probably won't cure them completely. There's probably other things that have to come in as well. Some of the other things I'll talk about in a moment, but certainly for psychosis, antipsychotics are very important, because without them, you are not on the same planet. But it's really just almost the beginning of the story, or one of the foundations, if that makes sense. There's then the psychology. How do you? Because even if you take antidepressants, there will still be perhaps a tendency to think negatively. How do you catch those thoughts early and turn them around, or take a more balanced perspective? There's so much that psychology and other types of therapy and counseling can treat us. But one of the really big things, I think, is the social side of depression. And we were talking a bit earlier about, the asylums, and people were taken in for a variety of right and wrong reasons. But quite often a year later, they were doing quite a little bit better. But the social effects of being in that sort of depersonalized environment, all of your clothes are taken away and you give them stripy pajamas. It's designed to reduce you to being a number. So that the sort of social effects on our mood are huge, and we all know examples of things like men's sheds or walking groups or this kind of thing, or this kind of talkathon. The importance of talking about men's mental health. One of the first high-profile people to speak about it, I suppose, was Alistair Campbell, Tony Blair's chief of staff, I think he was, wasn't he? Who had a major breakdown in the lobby of the Savoy Hotel in London, and had to be hospitalised. And this was in the middle of his time in office, and he was quite open about that. And it was one of the first times that it's really happened. Winston Churchill famously would speak about his black dog, but so I think being able to talk about this from a stigma point of view, but also just social inclusion. And if you're sat in a one-room flat, staring at your four walls, Monday is turning into Tuesday, is turning into Sunday, days turning into night, even if the negatives have been removed, it's very difficult to have positives in that situation. And then it's not just perhaps the loneliness and isolation. It could be debt. It could be fearing for your safety if you've been involved in the gang scene or the drug scene, and you've moved away from that, but you're still scared to go out. It could be people fleeing from war and things like that. And then there's also all the childhood determinants of just general childhood adversity, poverty, poor diet, sometimes abuse and trauma, bullying in school. And I think what we know is that if you add up all the numbers, there is a biological component to this, but actually to really make our nation mentally healthy, if that makes sense, the things we're not doing at the moment is looking at the social stuff, the inequalities, the bullying and stigma that goes on, the poverty. Those are the isolation. Loneliness is a huge problem among the elderly, in particular, among a lot of men as well, who perhaps don't tend to talk about emotions and things like that. So I think those are things. And the great thing about those are things that anyone can tackle. You don't need a medical degree to tackle loneliness. You just need to go and talk to someone, or maybe open up your business or your project, or redo your local community garden, or whatever it is. These are things that anyone can do. You just need to be community minded in some way.
That's the word that keeps coming up today, I think. Again, another one of the themes is community.
Community, yeah,
and how there's an intrinsic link with mental health, and as one Pastor Paul today called it, mental fitness. The mental fitness you can do on purpose. And a lot of our responses, at least we're having responses to mental health, but they're reactive rather than proactive. I don't know how many to what involvement you have when you see people. How many people, I'd be curious to know, can you tell straight away if they had this, and this in place, they wouldn't have even ended up here?
I think a lot of that. So I think, I'm sort of dealing with people once it's all happened, if that makes sense. It's kind of there. And I think, the biggest contrast actually was when I first got involved in Mercy. I was living in Leeds and Bradford, which is where the charity's based. And I was working in the community mental health team in city centre Bradford. And there was a huge contrast between your average young white guy with an episode of psychosis and your average young Pakistani guy with psychosis. Because when I saw the white guy, he was by himself. He would come to the clinic by himself. He probably was estranged from his parents, might have a problem with substance use. He perhaps had dropped out of school and didn't really know exactly what he was going to do. When I saw the young Asian guy with psychosis, I used to get 20 people in the room. Half the community used to come, the parents used to come, the local imam used to come, the brothers and the sisters and the cousins and the aunts used to come. And, I initially wanted to be sort of quite strict and say, no, it's very important I talk to the patient by themselves. And increasingly, I just went, come in, come in, because the more the merrier, because at least I know this person's held and caught. And, the times actually I would see that was when in the sort of white Caucasian population was either if there was a strong family, or quite often there was a strong community around that person. And sometimes that was a church community. So people would come with a couple of people from the church or someone like that would come to the appointment with them. And it's so important to have that, because I thought, right, that's one less thing for us to try and do. And the NHS is not very good at providing community. It's quite good at providing treatment and assigning professionals and things like that. But you're just getting to know one professional and they change or they retire or they move or something like that. So actually having genuine relationships in your life is hugely important. Also, when you go and see a doctor, you only retain about 10% of what you're told. So having someone with you who can actually remember that or help you put the plans into action is really important. And I think you're right, to some degree, a good chunk of that would have been preventable if people have been supported better to finish school or to find employment or education or training in some form.
And how do we do that? Where do we start? Like that, it feels like a really big problem to fix.
Yeah, I think one of the things is probably just to understand that is one of the big questions in mental health. I think there's two big questions in mental health. One is how does the brain work? And how do we fix it? And I think that is to the more biological end of things, more the sort of psychotic or the degenerative conditions like dementia or some of the other conditions like Huntington's chorea or multiple sclerosis that can result in psychotic symptoms or dementia symptoms or Down syndrome, for example. Whereas I think the more sort of, might broadly term them neurotic end of the spectrum, there is a genetic element there, and I think we will understand more about that. But actually, one of them is how do we change society to make these things happen less? We know that the countryside is better than the city. We know that peace is better than war. We know that a broad brushed, fairly stable spread of wealth is better than financial major poles of inequality. We know that the average mental health burden in a country is related to the degree of inequality in the country. We know all these things. We've known them for 30, 40 years. The person who did some of the earliest epidemiological work on mental health was a guy called George Brown, and he looked at risk factors for depression in women in Camberwell, which is a borough in London. And what he found out from his research was that the women who were most likely to get depression were people who had 3 children under the age of 5 at home, didn't have supportive parents, didn't have a confiding relationship. And I forget the other ones there, but basically he worked out these things, and there were two really interesting things about that. And I met George Brown because he came and lectured to us, and I said to him, does this only apply to women? Does this also apply to men? And he said, I think it does, but I couldn't study the men in Camberwell because they were in and out of prison. And he said it absolutely deadpan, but he was also absolutely true. He could not study this in a male population in the inner city of London because there was too much instability in that population. They were in and out of prison. That was one of the reasons why there weren't any confiding relationships for the women to have. But also, George Brown is not a psychologist or a psychiatrist, he's a sociologist. And that's one of the big sort of early studies on the risk factors for depression was done by a sociologist. So we know all these things. The problem is that they're not things that the NHS can fix in itself, apart from promoting the research, because they're not illnesses as such. It has to go right back to government policy, housing first, looking at policies that reduce financial inequality. And it's very difficult to do that. It becomes very, very political, and people get up on their high horse around various different things. And are you more left wing or right wing or so on? But actually, if you look at the sociology here and the risk factors for mental health, it's actually very clear.
That's really interesting. It makes me wonder imagine if churches all across the country all put a policy in place that checked in on people's mental health, or had some kind of program in place that just took everybody through, gave everybody that opportunity for some kind of talking or discipleship, call it what you will. I mean, obviously we have the keys to freedom, but which we encourage people to use. But I mean, imagine if hundreds of thousands of people all went through that, and what that would filter into society as a result. What difference would that make to the local GP surgery? What difference would that make into the local schools and colleges and workplaces where people's mental fitness, where people's mental health is well, because we all invested into it on purpose? What's your
that's the key thing. We've got to do two things. We've got to mainstream it, and we've got to be positive about it. So what I mean by mainstream it should be a question that we should ask everybody. So Christians Against Poverty, who are another big Christian charity who originate in Bradford, they have an HR policy where every year at the person's annual review, they're asked a couple of questions, like, first of all, how many duvet days have you had to take this? Like, I heard your previous speaker talking about, duvet days and just taking a bit of time off to look after your mental health. Absolutely fine to do that. We should all probably have 1 or 2 duvet days a year. And their policy is, up to 5, no questions asked. We just want to know, is there anything we could do to do it differently? But if it's a bit more than that, at least what they've done is they've kind of mainstreamed the topic of mental difficulty at the annual review. So it means that if you then need to go a bit further and say, well, actually, it was a bit more than that, and I'm really struggling in the role or something, you put it front and center, rather than a performance review being all about your sort of attendance and your timekeeping and your KPIs and how your performance in your job. They've sort of put it into everyone's annual review. And likewise in churches, I think we should have every Sunday, perhaps on World Mental Health Day, we have a mental health Sunday, and just talk about it as a topic. It's a huge topic in Scripture, our emotions. We don't have to talk about mental illness. We just need to talk about emotions.
Yes.
It's a huge topic in Scripture. Many churches might have, they'll have Easter Day and Christmas Day, and then they'll have, perhaps a missionary Sunday, or they might have a Christians Against Poverty Sunday. Let's have a mental health Sunday. And mainstream it. And I think what we don't want is for churches to sideline it by appointing a counsellor in that room over there with the door, and we all know that through that door is a place that is sort of got pastel colour paints and a big box of tissues, and that's where the weird people go to get their therapy. There's absolutely no problem in churches having counselling, but it must be after it has been mainstreamed in the whole church.
Yes.
In the same way that you don't appoint a youth worker to deal with the smelly youth, you actually let the youth run the Sunday a couple of times a year, and you take the risk that it could all go weird. But you know, when you give youth that place, then you can appoint a specialist, perhaps, to do some of the youth work. So we need to mainstream it, but we also need to mainstream it in a way that says this is not a label and a handicap. This is not a right. Okay, so you've got this. That's your excuse for not participating or living or existing. It's how can we help? How can we do this better? How can we get alongside someone? And you know, illnesses, some will be episodic, some will be more chronic, but people should still be able to flourish and live meaningful lives, even sometimes in the presence of ongoing symptoms. And that could be ongoing symptoms of cancer or chronic pain, or it could be ongoing symptoms of psychosis. You know, one definition of recovery in mental health services is to live a meaningful and fulfilled life, even in the presence of ongoing symptoms. Yeah. So, you know, the person can be quite, quote, unwell in that they might still be hearing voices, they might not be able to go back to their old job, but they are still able to feel as though they have a meaningful life, they are valued, they are loved, they have community, etc., etc.
Yeah, thanks so much for that, Rob. We've got you for about another 10-15 minutes. I've still got a whole list of questions. One of them that I feel like it's really important to ask and get your take on is just to kind of go back to something we were talking about before, which is to be quite specific around it. It's the role of antidepressants, because there's still a lot of stigma around it. And a lot of confusion around it, and there's a lot of different understandings and perceptions of the good and bad sides. And I would love for you to reframe our understanding of the role that medication can play. When is it really helpful for providing stability so somebody can do the deep work? When is it sometimes prescribed when actually it isn't the right thing? But just to reframe that for us, because I think it's a tragedy that even in our industry, I think that there's still a lot of wariness around the use of medication, and a lot of just a lack of understanding of the role that it can play in somebody's healing journey.
Definitely. So I think the first thing, let's start with the name, antidepressant. It's not a very good name, is it? Because it doesn't always make you undepressed. Yeah. A better name is a serotonin raiser. So it raises the level of serotonin in the brain, and low serotonin is associated with clinical depression. There was a big study that came out and got front page headlines in the Times, you know, sort of six months or so ago. You know, serotonin theory of depression under fire. You know, these people had done this analysis and debunked it, and it was effectively a very, very damaging paper ultimately, because they only analysed half the research, didn't do it very well, and they've had to republish some more findings since. Low serotonin in the brain is associated with clinical depression. We know that from animal models of depression, we know it from brain scans, we know it from the mechanism of action of these drugs. So that is without doubt a truth. I think what I would say is, first of all, that's kind of the final common pathway of depression. There are many pathways coming in to depression. Some of them could be those social determinants we spoke about beforehand. Some of it could be genes, in terms of which genes are expressed, or a family history, or the interaction between our genes and environments, or it could be how our psychological or trauma approaches or our traumas in the past perhaps have led us to express other genes that result in low serotonin. So there's all these various different causes of depression, but one of the end products and final common pathway does seem to be low serotonin, particularly when that is associated with what we call the biological symptoms of depression. So interestingly enough, you don't actually have to have low mood to get a diagnosis of depression. There are three core symptoms of depression, okay? Profound tiredness, what's called anhedonia, which is a loss of pleasure, and low mood. Now, you only need 2 out of those 3. So it's
Mm.
possible to have the first 2 and not the third one. And we sometimes see this classically in older people who have effectively become bedbound. They are very, very tired. They don't get any enjoyment from things. They often don't report low mood. Now, why is that? Is that because they don't have that symptom, or because culturally they don't talk about it? I don't know. But but what they do have is they have all the biological symptoms that go with it. So what we're talking about here is disrupted sleep, affecting the biology down below. Important for men, impotence. Okay, let's talk about that. That can be a symptom of depression, and also weight loss or significant overeating. Significant impairment in concentration. You know, we're almost at the point where it can look like the beginnings of dementia. These are the biological symptoms of depression, and those are the ones that are more associated with low serotonin, and those are the things where raising serotonin can be absolutely transformatory. Where antidepressants are less good is if it is more just unhappiness and dissatisfaction, boredom, feeling the universe is against you, not sure if anyone likes you, those sorts of things. Those things perhaps have a more psychological root. They're perhaps more towards the low self-esteem end of things. The person is often still functioning quite well, whereas a person with biological symptoms of depression probably won't be functioning. They'll be missing things because of this cognitive impairment. They won't be sleeping. They'll be losing weight. So the more biological symptoms you have, the more role there is for antidepressants, and the more we would sort of push that. And we could take that even further, perhaps, into other treatments like lithium and that kind of thing. You know, more specialist treatments. Whereas perhaps the less biological symptoms you have, and the more it's the sort of unhappiness end of things, we have thinking that's more psychological, or of course it could be social. You know, it could be that the person is homeless and destitute and hungry and all the rest of it, and that's the bit that needs fixing first. So what I say is that there's definitely, we know that antidepressants work, and like I say, sometimes we can poo-poo them, but I'll just take you back to 1960 when people lay on their beds for 6 months. And antidepressants enabled them to get up. It's as simple as that. They enabled thousands of people to leave the asylum. What I would say is, though, that again, it should always be antidepressants and something. So it shouldn't just be antidepressants. It should always be antidepressants and, I'll be fairly broad here, but you know, therapy, counselling, the freedom course, etc. Something. Okay, again, the more biological symptoms of depression, we want to be talking about specifically things like cognitive behavioral therapy, but in the broader scheme of things, counselling or courses like the freedom course. And of course, you know, the great thing about Christianity is that it does encourage us to examine ourselves. What we need to do is make sure that we examine ourselves with the aid of other people in a community in a helpful way, knowing that God loves us, rather than navel gazing and suspecting he doesn't. So I think they've got a huge place. And what I would say is, if you're not quite sure, have a chat to your GP and try a modern antidepressant at a low dose and build it up slowly. By and large, they don't have dangerous side effects. They can have side effects in some people, but it's normally more things like perhaps a rash or a bit of nausea or something. You know, people can read the leaflets, but they're generally speaking, they're always reversible side effects. And what I would say is, you know, if it works and you're one of those people whose brain is transformed by being on an antidepressant, why should we think any more negatively of that than someone who is diabetic and needs to take insulin? Or some chap I was reading about in the BBC News this morning who has had haemophilia and has now had gene therapy and is cured, you know, and no longer needs to take factor VIII injections. So we're changing a bit of the brain biochemistry, sure, but we know it works, and we know that it decreases suicide. There's all these things that we know about antidepressants. So it's really important not to avoid them, but don't just do it. Also, definitely get some kind of therapy alongside that, and make sure that those unaddressed social things like debt and loneliness and so on are also being addressed.
Yeah, that's an incredible reframing. That's really helpful.
Brilliant.
Do you have any questions, Paul? I've got a couple, but the ones I've got are too big. I think I feel like I'd be introducing a can of worms, and we've got 5 minutes to go.
I tell you what.
Yeah.
Let me introduce one. Okay, I'll tell people a story about Mercy.
Yeah.
The first time I went to the Mercy headquarters was to strip out the old house, and Mercy had been effectively given or allowed to use this house, and it was an old Victorian house, and it was stripped out, and all kinds of stuff was being thrown in a skip. And one of the things that was being thrown in a skip, I'm not entirely sure if I'm going to try and turn my screen around. This could be dangerous. You might be able to see on the wall, just there, in the corner of the room, in the corner of my room, up on the wall. I know it's a bit blurred because I got my blur turned on.
Yeah,
you might be able to see. You might be able to see a drinks cabinet on the wall.
Yeah, sorry.
And I rescued that drinks cabinet from the skip that was going on in Mercy, and I have in my hand here a rather fine Scottish malt, because I live in Scotland, and I wasn't quite sure if it was 10 o'clock, if that was too early, but I might have a wee sip now just as you move on to your next guest. So what I thought, there's 2 reasons I wanted to get this out. One is, I think sometimes men can talk and bond over a drink, and actually I think that can be quite important. And you go to the pub and you have a good chat, and that's really important. The flip side of that, of course, is that men can use drink badly with alcoholism, or to numb emotions that they ought to be talking about. So I just thought, that might be something you might want to pick up or talk about in the early hours of the morning if you've got some quieter slots. Is how does addiction, the good use of a fine malt to provoke conversation sat around a fire or in a nice snug. There's a lovely definition of community, when good friends turn their chairs inwards and talk well. And sometimes that can be facilitated by a wee nip. But there's also the bad side of it, where people use drink for bad. So I'm going to have a wee toast once we've finished. But I don't know if that's something you discussed today, or something you could get around to later in the session.
I would imagine it will come up at some point. I think it's a good prompt, Rob. A good prompt. Thank you. And you enjoy your wee dram.
James Ray did talk about the need to find balance, and actually how getting that balance right is the key thing. And I feel like that's a good example. It's we don't need to go one extreme to the other. It's actually finding the balance. I think, and
having good friends who can keep you accountable. That's the key thing, isn't it? Because some people can drink in moderation, some people can't. Some people need to be abstinent for a time to refine their balance, and then perhaps could drink again. And that could be due of alcohol, it could be due of sport, it could be due of our jobs. All of these things, we need to have that community perspective around it.
Rob, that has been a really fascinating conversation. I've really appreciated just the breadth and the depth that you've brought into this issue, and just take an opportunity to thank you in front of the nation. Let's pretend the nation is watching. The role that you have played.
Are they not? Are they not? I was told they were.
But yeah, the role that you have played for Mercy over the years, you're a constant advocate and cheerleader, and we feel it all the time. So thank you for playing that role. We really do appreciate it. Thank
you.
Yeah, we've got a fellow board member on next. Jonathan Clark from Premier Lifeline. So really looking forward to that. We'll let you go off to your whiskey, Rob. You've earned it.
Perfect. Well, thank you so much. And I'm off tomorrow to the Scottish Highlands with 30 scouts going camping in a field for a week. So I said my wife has a classroom full of kids, but that's my madness. But I think getting out in the countryside, mostly boys, a couple of girls coming along, and a bunch of leaders. We're just going to go and live in a field for a week and have a ball. That is so good for your soul and your health and your spirit and everything else. Maybe not my back, but we'll see.
Enjoy.
All right. Take care. Bye.
Yeah, Rob, take care.
Bye, Rob.